So we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and Tsleil-Waututh nations, and the Métis chartered community of the Lower Mainland region. And today, thankfully, in the Lower Mainland, it is not raining, and it's actually going to be a beautiful sunrise, I think. And all of you to reflect on where you are in this province or other places in Turtle Island. As we reflect on the land and the people who have been on it since time immemorial. Next slide. Province-wide rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. We're thankful to all of our industry partners, as well as, importantly, all of our health authority partners that facilitate this educational venue that we share and learn together, that we take better care of our patients in an evidence-informed way. Next slide. So it's really my pleasure to introduce Dr. Victor Leung. Importantly, Dr. Leung is a clinical professor of medicine at the University of British Columbia in the Department of Pathology and Lab Medicine. He's also the medical director for infection prevention and control and the physician lead for antimicrobial stewardship at Providence Healthcare, and has really played a major role in facilitating optimal management in our province in many ways. So Victor, over to you so that we can better inform how we vaccinate and why we vaccinate people living with chronic kidney disease. Thanks again for agreeing to do this.
Thank you, Adira, and good morning, everyone. Thanks for having me give rounds for the next little bit. I'm just going to switch over now to presentation. Just to check to see that okay, it's working. So for today, these are my disclosures for this topic. Some of the work I've done before is related to vaccines, and these are my disclosures for volunteer work that's not related to medications or vaccines. So the objective today is to recognize the importance. Actually, sorry, you know what? I pulled up the wrong one. Sorry about that. I'm just going to stop share there because we've done.
That's a different talk.
Sorry about that. Sorry, I should get to this very quickly. Share. Okay, so sorry, the objectives I had in the wrong slide set, but the objectives were presented on the previous announcement. It's for us to provide, hopefully in the next a little bit, provide an update for specialists and groups outside of infectious disease public health to be aware of their role in and importance in updating vaccine programs. And I'm going to provide some examples of ways that programs have trialed to improve vaccine uptake. And specifically, vaccines that I'll cover will be vaccines that are important in patients living with chronic kidney disease. So just overall for vaccines, we know that they have been tremendously important in reducing mortality, and childhood vaccinations from 1974 to 2024, this is an infographic from Our World in Data, shows that the types of vaccines that have led to the most significant decrease in mortality being ranked. And if we look at the top vaccine that has its impact, it's with measles vaccination. So the mortality from measles vaccine is not necessarily because people were dying directly from measles, but because after acquisition of measles, there are significant long-term sequelae that happen in children or adults, and that long-term sequelae has to do with the immune system. So now we know there is a major impact of measles infection on immune amnesia. And when an individual is exposed to measles, after recovery, their immune system is weakened and predisposed to infections that they may have encountered previously, making them, again, more susceptible. So people die of, for example, bacterial pneumonias after measles and are at risk for that before they are re-exposed again to different pathogens and develop longer-term immunity. Now in Canada and in other places, Canada has recently lost its status for measles elimination, and that largely has to do with under-vaccination in many different areas because for various reasons, not meeting the vaccine targets that are considered protective for herd immunity. Now, vaccines in this US have played a major role in terms of public health systems. Even though we've seen a lot of changes in the US, this was recently a letter in October talking about how even the president's physician has updated his vaccines that include the annual influenza and COVID booster vaccines. This is in a setting where in the US, the administrative arms have significantly impacted public health programs, and specifically the US CDC has been a long-standing sort of resource globally for vaccines and public health. But recently, in November 19th, they've revised their website on vaccines and autism to state that vaccines, the claim that vaccines do not cause autism is not an evidence-based claim because studies have not ruled out the possibility that infant vaccines cause autism. And that change in wording has had significant impacts on how public health organizations and even specialty organizations like the American Academy of Pediatrics have come out to voice their concerns and distrust for what was previously known as public health organizations that have significant impact. And now the concern is that these public health organizations are losing credibility, not only because of previous decisions related to COVID, but also now political decisions that have impacted how the programs are funded and who's making the decisions around what is considered evidence-based resources for the public. So with all these barriers now that add on to the difficulty for people to get adequate information about vaccines, it's extremely important for healthcare providers, to be aware of how they can help promote vaccine preventable diseases and uptake of vaccines. And this is just some surveys that have been done by various companies overcoming barriers to vaccines. The first barrier is having the patient be aware, and a lot of times the patients are not aware because there is different information out there about what is considered being up to date or having recommended vaccines that are public health funded, and those that are indicated but maybe not yet funded in the current system. Although cost was not the most significant barrier for some of these vaccines that are available now in Canada and recommended for certain groups, the cost does become a significant barrier, and there is unequal sort of distribution of which vaccines are funded depending on which province people live in. So one of the things we can do as healthcare providers is to make vaccine recommendations for our patients to be aware of what's recommended, make it clear, and make it easy to administer. So from a discussion point of view, talking about vaccines, whether it be through our visits or through campaigns, is important to ensure that the discussions around vaccines aren't lost, and that we take some responsibility too for health promotion and disease prevention, and not rely only on the traditional routes from public health because of changes and the resources available from the public health side to both deliver and administer vaccines. And then secondly, make our recommendations clear so that they understand what is recommended for their specific conditions. And finally, making it easy to administer, which is the challenging part. Now, although we say that that point may be easy to overcome, there are a lot of challenges, and I'll talk about what we've done to try to overcome that. But even when we've tried to deliver programs to improve vaccine uptake in hospitals, there are a lot of logistical challenges. So this campaign that's been put out by your group has been very helpful because it's multiple different groups and specialists that make people aware of what's indicated based on their disease population. Patients with chronic kidney disease have specific needs for certain vaccines, and making it clear here for routine vaccines is very important to highlight. So when we think about the types of vaccines and why certain individuals would be more predisposed to certain diseases, aging is definitely one of the biggest risk factors for poor outcomes from infections. And chronic medical conditions will compound that risk. And we'll see with some of these diseases I'll talk about next how these conditions increase significantly the risk for poor outcomes in these certain conditions. Now, with chronic kidney disease, depending on the age, even younger individuals with chronic kidney disease may have similar risks as an older individual because of immune senescence. And with advanced chronic kidney disease, both the innate and adaptive immune system arms are compromised, putting people more at risk of some of these diseases. And the challenges with chronic conditions is this bidirectional relationship of both inflammation from chronic kidney, for example, chronic kidney disease, and then susceptibility to some of these infectious disease that then form another inflammatory condition. And this vicious cycle of disease and infectious disease and chronic disease could potentially be reduced, and with the severity being reduced with vaccinations. The challenge with this is that in individuals that have immune senescence, we need different strategies to improve immune response. Now we know that some of the routine vaccines we're delivering now, for example, hepatitis B, sometimes the formulations need to have higher antigen content, so we increase the dose, or we modify the schedule for people who show a lack of sero response. The other strategy is to formulate vaccines that have adjuvants that are more that can be more immunogenic and deliver a more robust response, or at least a response that's equal to individuals who don't have these chronic diseases. And then the third strategy is to consider alternative administration routes. Now, the vaccine manufacturers are not as interested in trying to formulate vaccines with different administration routes because of the cost of doing so, and the trials to show that these alternative delivery routes are as efficacious as the traditional ones. And some of these administration routes could just include intradermal routes. For example, some of the vaccines that have been long-standing have studies for intradermal delivery, and now hopefully in the next few years there will be more intranasal delivery of some of these vaccines to stimulate more mucosal immunity for respiratory viruses, as an example. So the first disease, I'll cover three examples, and if there's time, I'll cover a fourth one. And I'll state its relevance in terms of British Columbia, because throughout the provinces, how vaccines are covered and the restrictions are different. Overall, in Canada, the National Advisory Committee on Immunization reviews the evidence and makes recommendations for Canada on which vaccines are indicated, specifically also for certain groups with multiple comorbidities. The challenge then is that the province's administration, because of the federal, provincial, territorial financial transfers, it's up to each province then to deliver on and decide which of those vaccines will be funded and how it will be further restricted. In British Columbia, for example, compared to Alberta or Ontario, some of these vaccine restrictions are quite different, and it ultimately comes down to what the Treasury Board will fund. Although public health makes these recommendations usually consistent with NACI, the challenge ultimately is the financial implications. So with pneumococcal vaccines, we know that severe strep pneumo is a very significant disease, and we often see people in our ICU with strep pneumomeningitis, severe pneumonia. This is the most common cause of community-acquired bacterial pneumonia, and when it leads to a more invasive disease, that's when the burden of illness becomes quite significant, leading to significant mortality. With pneumococcal vaccine serotypes, over the years, the vaccines have been produced either as conjugate vaccines or polysaccharide vaccines, and the multiple serotypes are based on surveillance data. The challenge is when invasive pneumococcal strains are isolated from sterile body fluids and submitted for serotyping. That data is collated, but it's often delayed in terms of how it's reported. So for each province, individuals that may have various serotypes, we don't get as real-time data on which serotypes are causing invasive disease. And it's quite variable based on age as well as where people are. So the provincial serotype data is variable. And so currently in Canada now, the recommendations are for either the vaccine that covers 20 serotypes or 21 serotypes. In British Columbia, the vaccine that is covered is the PCV20, the one that covers 20 serotypes. So the NACI recommendations for this vaccine are really for adult programs that I'll cover, and they say that individuals in Canada should have at least one of PCV20 or PCV21. With BC adopting some of these criteria, because of the funding restrictions, they've made additional restrictions for who they will publicly fund the PCV20 vaccine for. So in British Columbia, the bottom line is that if individuals have CKD, then you can administer PCV20 if they haven't received PCV21. So most individuals that we see have not received PCV21 because that one would have been paid for by private insurance, or maybe they received it in another province. But in BC, they're more likely to have received the polysaccharide 23-valent vaccine. So if urine patients have not received 2 doses of the polysaccharide vaccine, then they qualify for PCV20. Now, this brings a challenge logistically because of our vaccine record systems in Canada and in British Columbia. Although BC is touted to have a vaccine record system, a better vaccine system compared to some of the other provinces like Ontario, we don't get access to the systems, and not all the data is entered depending on where people would have received their vaccines. For example, through family physician offices, pharmacies, or hospitals. In the hospital setting, we can look at the electronic health record system where you're working to see if it captures what their vaccines are. We can look at Care Connect that may be linked to some of the public health data. So it's an advantage and disadvantage for some vaccines, because if there are no records, then pharmacy will not restrict it, because pharmacies in hospital receive the vaccines from public health funding, and they will, depending on which programs you're in, they will check and sometimes add the restriction that if they have received PPSV 23 times 2, they won't release the PCV20 vaccine. However, because most of the records are quite disparate, a lot of the people that we've reviewed in hospital don't have adequate records, in which case it's easier to just give the PCV20 vaccine if the records are not available. So something to think about in our system, and I don't know with the provincial renal registry how accurately captured previous vaccines are, but one way to improve uptake of the current recommendations for bacterial pneumonia, specifically strep pneumo, is if the individuals don't meet those two criteria of having previously received them, then we can just provide the PCV20 vaccine. It's an intramuscular vaccine, and most of the people that we've approached in hospital to avoid a missed vaccination opportunity during their hospitalization have been open to receiving it, and we just do the consent statement as well as just ordering it while in hospital. So with moving on to two other diseases, before I go on to those infections, I just wanted to quickly review vaccine efficacy, because there will be numbers mentioned related to vaccine efficacy when I talk about these two other infections. So the vaccine efficacy number that we get usually comes from clinical trials in the setting of conditions that the trials were conducted, and it calculates the relative risk of the outcome depending on if subjects receive the vaccine or if they receive placebo. So, for example, when we talk about a vaccine that has an efficacy of 80%, it means that those who are vaccinated were at 80% lower risk of developing the disease outcome compared to the placebo group. And I just wanted to put that as a reminder, because sometimes when we're talking to patients and they have questions about what that number means, it might get misinterpreted and sometimes misunderstood. So the first case I'm going to talk about is a case I saw in hospital a few months ago for an elderly man who was admitted to hospital with zoster, but he developed a severe complication, and that was zoster encephalitis. Several months prior to his admission to hospital, he presented to emergency room at another hospital and was diagnosed with Bell's palsy. He was given prednisone and discharged. Unfortunately, the prednisone dose and the prescription was incorrect, and he ended up taking 70 milligrams of prednisone for a period of a month. And after they realized that that was a medication prescription error, several weeks later, he presented to hospital with zoster and altered level of consciousness. And based on CSF analysis, post-lumbar puncture, he was diagnosed with zoster encephalitis. So herpes zoster, we see it from time to time, and usually in hospital we see the more severe forms, those admitted because of eye involvement or disseminated disease, or disease that results in such severe pain and other sequelae that leads to complications in other organs. So the natural course of herpes zoster usually starts with the prodrome, non-specific. Most individuals will develop an acute vesicular rash, and sometimes it comes on very quickly, sometimes it's delayed, involving multiple dermatomes. The most common area it'll involve is the truncal area with thoracic dermatomes, and then the second most common is the face. And if it involves the cranial nerves, certain cranial nerves, it can lead to ocular, auditory complications that can be very debilitating and significant, with long-lasting impacts, including visual impairment and, for some individuals, tinnitus or hearing loss. And then some individuals will develop more chronic problems like post-herpetic neuralgia. Now, the problem with herpes zoster is because individuals who develop this think that, well, now they may have gone through a previous episode and are no longer susceptible. The recurrence rate is significant. People can have multiple episodes of zoster throughout their lifetime. And if the disease occurs, the rash and the post-herpetic neuralgia, even if that resolves, some of these other risk factors or residual risks, such as cardiovascular and cerebrovascular events, are still at heightened risk compared to individuals who don't have an incident case of zoster. Now, we know that age is going to be the biggest driver of immune senescence and the risk for herpes zoster. Over 2/3 of cases are those over 50 years old. And that's why in Canada, the recommendations are for any individual over 50 that they be vaccinated for zoster. For those under 50 years old, if there's a high-risk comorbidity, they also qualify. Usually it's primary immunodeficiencies and some of the more significant secondary immunodeficiencies affecting T and B cell function. So when it comes to cardiovascular events, the impact of zoster is significant. This is from the Nurses' Health Study and Health Professional Follow-up Study sub-analysis that enrolled a large number, 95,000 women in the NHS, and the health professional sub-analysis study also included males, looking at time from zoster infection to adjusted risk for stroke and for cardiac events. So we can see that the hazard ratios for those are all above 1. And when compared to some of these other diseases that we traditionally think about as immunodeficiencies, they are quite significant and possibly vaccine preventable. Meta-analysis and systematic reviews that include over 7.9 million individuals now show that within 3 months of having an incident zoster case, the odds of having a cardiovascular and cerebrovascular event are increased significantly. And while the further out you go from a zoster event after the 3 months, the risk is still high, but the cerebrovascular risk remains significant, whereas the cardiovascular risk seems to decline after the first 3 months. So previously we had different forms of vaccines for zoster. The only available one now in Canada is a non-live adjuvanted recombinant zoster vaccine. So this replaces some of the previous live vaccine that some of our patients may have received. However, the live vaccine was not as durable. And part of the reason of durability is because in individuals who get zoster, because of immunosenescence, we needed this other strategy to promote higher immunogenicity. So the vaccine that's available now is coupled with an adjuvant system, 2 adjuvants. There are immunostimulants that help increase durability as well as response to immediate vaccination. So the vaccine is a 2-dose vaccine, and now we have over 11 years worth of data looking at how durable that vaccine is. That corroborates the previous recommendations for the schedule, which is a 2-dose vaccine separated by at least 2 months. So when we look at individuals who are vaccinated through the 2 large randomized control trials, Zoe 50, looking at the 50-year-old age group, and then Zoe 70, looking at older adults, see that the vaccine efficacy does decline, but if we go further out, the decline is still shows a significant degree of protection. So those who have received the 2-dose vaccine, there's no recommendations for booster because it appears that the vaccine is still quite efficacious in preventing zoster events and for prevention of post-herpetic neuralgia. So it'll be important to follow this and from an observational standpoint, looking at populations who've received the vaccines and other outcomes that develop. There are now some data showing that those individuals who've received the vaccine are less likely to develop some other neurologic complications, including dementia. Now, this is based on several different observational studies, and I think that there's going to be more data there showing that the impact of this vaccine is more significant than just protection against an incident case of zoster, and hopefully has more downstream benefits in terms of other organ systems. So it's the biggest challenge with the zoster vaccine in British Columbia is it's not funded. There is ongoing work to see if we can show benefits in terms of economic value in certain groups. So, for example, in the BC Centre for Excellence in HIV/AIDS, the work has been done showing that in our population in BC, the hazard ratios of having HIV alone are very significant in predisposing to zoster. However, the vaccine is not funded, and hopefully with some of the economic analysis data, it may present a business case for the government to fund certain groups. And I'm aware that transplant groups are also looking at this to see if they can get it funded for that population at the highest risk, and just seeing if we can identify highest risk groups for which the government will end up funding. In British Columbia currently, the only group that can have access to it is if individuals have some private insurance. So a few limited private insurances do cover this, and also First Nations Health Benefits Program. So we tried to take advantage of the groups that are funded to promote vaccine in hospital setting with the pilot program in collaboration with the First Nations Health Authority. Once a week right now, we're looking at individuals who self-identify as First Nations and check to see if they have Plan W coverage. So if they have status number, then they have Plan W coverage. Then we consent them for the vaccine. And out of the individuals we've approached so far, over 90% consent to the vaccine. Most individuals were not even aware they were covered based on these benefits. We order the vaccine from the pharmacy across the street at the hospital, and it gets brought in through non-formulary status and administered in hospital. And then when they are discharged, it's added to their medication reconciliation list so that they can pick it up for their second dose to avoid all those complications of having to have a missed vaccine dose or missed vaccine initiation if they're not aware that they're covered. So I think that's another example where potentially the Provincial Renal Agency could check to see how many of their patients have Plan W status, and if they do, is there a way to just automatically provide that vaccine through coverage from First Nations Health Benefits. The challenge is that it is a lot of paperwork, because if individuals are under 60 years old, they require an additional form that just says what comorbidity they have. So some of the individuals we approach, we just have to wait until it gets approved by the First Nations Health Benefits Program. That usually takes 24 hours, sometimes up to a week before approval. Once we develop this and show the data with the First Nations health benefits. Hopefully that other hospitals can take a similar approach, but we have to work out some of the logistics because of still the barriers between formulary vaccines and vaccines that are not on formulary, since hospitals will not carry any of the non-formulary vaccines on stock. So going back to the case of the individual who developed zoster encephalitis in hospital, it caused significant impairment in his function. He was no longer independent with ADLs and was in hospital for many months trying to figure out a disposition plan. The plan was for long-term care because of his significant deterioration. But while in hospital, he acquired RSV. So this was a hospital-acquired case of respiratory syncytial virus, and he further deteriorated from that with pneumonia, and that led to much more prolonged hospitalization and a delay of transfer to long-term care. So the second disease that I wanted to cover is respiratory syncytial virus. Thinking about the burden of this disease, because previously we didn't have a vaccine for this, although many years they've developed vaccines that have failed. Now we do have 2 vaccines that are available for RSV that have been proven to be more efficacious than previous vaccines that are available. So when we think of respiratory syncytial virus, it has been one of the top viruses now that are included in respiratory surveillance data. It is a virus that is included in more of the testing platforms that are available, both in the outpatient and inpatient setting. And so from a public health standpoint, it's one of the top vaccines that's reported on in terms of surveillance because of its impact on hospital admissions and mortality, depending on which age group is affected. So currently, if we look at RSV in the bottom left, compared to incident cases of influenza A and B and SARS-CoV-2, it is still relatively low in terms of absolute numbers. However, when it is tested during respiratory season, the percent positivity is high. And these are tests usually conducted in individuals that seek health care in emergency rooms or in hospital, patients who are already in hospital. So RSV affects 2 different age groups, and that's why the vaccines are available and may be covered for these individuals. For children, it is the leading cause of respiratory infection resulting in hospitalization for bronchiolitis. And so in British Columbia, we have 2 programs for vaccination to try to reduce this impact. One is in women who are in their 3rd trimester, 32 to 36 weeks, or if they did not get vaccination during pregnancy, or individuals who didn't get vaccination during the pregnancy, then for the neonates to get passive immunity through nirsevimab. In British Columbia, compared to Ontario, nirsevimab has many restrictions, and that's run through a program at BC Children's Hospital. So they need to meet all the criteria before that's available. However, one of the main changes this year is for women in their 3rd trimester. Again, if they qualify for funded vaccine because they have First Nations health benefits, then the main change this year is that they don't have to pay up front. So hopefully to streamline and increase uptake and reduce the barrier of having to pay up front and get reimbursed, the program now provides coverage through pharmacies if they have Plan W coverage. Now the challenge is that the other population that's affected is the elderly. So they are more susceptible to mortality from this disease, and they make up the greatest proportion of individuals who die from RSV. In British Columbia, it's currently not covered for that age group compared to some of the other provinces. We know that elderly individuals will often have multiple comorbidities, so asthma, CKD, COPD, coronary artery disease, each of these comorbidities increases the risk of RSV complications. So if we look at the age groups of 50 to 64 versus 65 to 74 and those over 75, that overall risk is increased. But if we just look at individuals who are over 75 years old, those with no chronic conditions have lower rates of RSV-associated hospitalization, whereas if you have 2 or more conditions, you have a significant increase in your risk of RSV-associated complications. For respiratory viruses, we've long known that influenza has a major impact on cardiovascular events. But some of these other respiratory viruses have impacts that were not previously known to be as significant. If we look at RSV, for example, it is the second leading cause of viruses that we detect that are associated with cardiovascular events, including heart failure, arrhythmias, and myocardial infarction. So in provincial data on Ontario has shown this increased risk. And that's may have been contributing to why Ontario has different funding criteria and allows for publicly health funded vaccines for RSV in some of the elderly population. So in Canada, we have 3 vaccines that have been approved. For accessibility, there are just 2 vaccines that are available in the pharmacies right now. And these are the 2 vaccines are both public, neither are public health funded. I'm just going to quickly go over the efficacy data for these 2 vaccines. The randomized controlled trials that led to the approval occurred during the first season when they had the data, but then they subsequently followed out to 3 seasons for the Arexvy vaccine that shows sustained efficacy. So currently there are none of the vaccines for RSV have a booster recommendation because of the seasonal efficacy that's been shown for the 2nd and 3rd season for this vaccine. Whereas for the Bristol vaccine, we have currently 2 seasons of data, and the vaccine that we have the least data for is the mRNA vaccine. And that vaccine is not currently available, although it is approved. When we look at the vaccine efficacy data for both these for both these vaccines in the randomized controlled trials, these were not head-to-head randomized controlled trials, and the outcomes were slightly modified. So they looked at lower respiratory tract infection and severe lower respiratory tract infection based on different definitions. So we can't directly compare the efficacy of these 2 vaccines in terms of which one may be superior. However, both of the vaccines did meet criteria and have been approved in the US, in Canada, and now in the US there is more outcomes data looking at hospitalization impacts. Similarly, in Canada, several provinces have looked at its impact and who would be at highest risk for receiving the vaccine, and that is consistent with NACI's recommendations that those who are over 75 years old with modifying risk factors or adults over 60 years old in nursing homes where it's easy for the disease to be transmitted and amplified, that they are the group that have the strongest recommendations to receive the vaccines. And then there's discretionary recommendations for those who are 60 to 74 in the community, maybe without these comorbidities, who could still benefit, but it's not the strongest recommendation because they are not likely to get the most severe outcomes. So from a public health standpoint for value, it's going to be targeting the adults 75 and older who have multiple comorbidities. Now, there are indications now that have been expanded this season for those who are 50 to 59 years old at increased risk. But if we're going to think about focusing on programs that may have the highest value, we're still going to focus on those who are 75 and older, with the goal of preventing hospitalization and the sequelae of RSV disease. So it's great that now multiple organizations have come out with vaccine recommendations that are concordant, looking at various diseases. So for example, for RSV, the global COPD guidelines, global asthma guidelines, American diabetes guidelines, Canadian Thoracic Society, and more recently, the American College of Cardiology have come out explicitly to state that these vaccines are recommended in individuals with comorbidities because they see the impact on the population that have the highest risks. And I think that this is important because it helps amplify the public health message, which may not have been as strong and result in lower uptake if other physicians and health organizations don't come up with similar statements. So in summary, for individuals living with chronic kidney disease, they are at higher risk, and there are already very established vaccine programs. The areas where we may be having gaps are for vaccines that are public health funded right now that may have lower uptake. For example, the strep pneumo vaccine. So one of the things that we can do is try to figure out from a systems level, how can we most effectively deliver the vaccines for the people at risk when it is public health funded. And then for those non-publicly health funded vaccines that are recommended in Canada and nationally for highest risk groups, how do we deliver the vaccine to individuals that are currently already have funding effectively through provincial programs. And I guess a reminder for all of us to think about some of these diseases and its impact not only on preventing the infection itself, but also the downstream sequelae, because some of these diseases have multi-system impacts that patients should be aware of and could benefit from vaccine administration early on prior to disease development. And even if, for example, with zoster, even if individuals have had zoster before, how do we provide them with the vaccine to prevent future incident cases of recurrent zoster? So I'll stop there and try to address any questions and discussion. Thank you.
Thanks a lot, Victor, for a really comprehensive overview. And I think importantly for this audience, the fact that these vaccines are protective not just for the infection, I think, but for the downstream impacts in terms of cardiovascular disease, which I think is quite important. One of our patient partners is asking why the zoster vaccine is not recommended in CKD.
So the zoster vaccine is recommended in individuals living with chronic kidney disease. Sometimes people think about the previous zoster vaccine, which was a live vaccine, and for some individuals with the highest risk immunodeficiencies, there was hesitancy because of lack of data. But currently, the zoster vaccine, the recombinant vaccine, is recommended for individuals living with CKD. So the main recommendations are anyone over 50 years old, and if you're between 18 and 50 years old with a comorbidity that puts you at increased risk. The challenge is that it's not public health funded currently in British Columbia. And so the discrepancy is
in the type of vaccine, the previous. No. Yeah, thanks for the question, Mauricio. I think it is great because, I mean, as Victor's pointing out, the technology in vaccines is changing, and therefore who can get what when is changing. And so it's really important that we keep up to date on that. So in answer to one of your questions earlier, for BC, all patients registered with BC Renal, we actually have an automatic feed from Panorama, so we actually know who got vaccinated. And what we did notice in the last 3 years since COVID, that there's been a 50% reduction in vaccination across all CKD patients and dialysis patients. And so one of the objectives, if you will, of today's talk from you, as well as all those posters that we created, is to really encourage all of us within the renal community to remind our patients to get vaccinated, even if we don't have control over where they get vaccinated. Because you really want to change that, especially given the added cardiovascular risks that they have anyways, and then the fact that these infections amplify those. So really helpful for you to show the first slide, which showed that healthcare professionals advocating for these vaccines are actually the best way for patients to uptake. Hazel, you have a question.
Yeah, I'm wondering if there are any specific considerations for any of the travel vaccines um, in this population. Yeah.
Yeah. So the challenge with travel vaccines, it's expensive. It is still very important, and patients don't have good access to say where to go for recommendations. There are travel clinics in British Columbia; those are all private pay. What I generally recommend for individuals going on travel is to use the best resource still I find is CDC travel website, because you go to the country or the country's locations of where they're going to go. It puts out reminders of the diseases that are currently being of importance, and then it reminds them of the vaccines that are standard. For example, the highest risk ones, hepatitis is common, hepatitis B, for example, and some of these vaccines are publicly health funded, so they can get them. But then for some of these other ones, depending on where they're traveling, they aren't. But at least then they can get the recommendations that is what usually public travel clinics recommend anyway, and that may decrease the cost of having to pay for an additional consultation, because then they can evaluate for themselves, well, which disease is currently at high incidence, which disease is going to be of most importance, and then when they think about the financial impacts, which one they want to prioritize to receive, because these are all private pay.
I guess the question is more, is there any consideration to vaccines that they shouldn't have? Just from harm or, yeah, I mean, obviously the same as everyone else, right? That you would receive the usual vaccines or risk factors whenever you're traveling. But is there anything in addition for this population that a person needs to be considerate of?
Yeah, not for chronic kidney disease itself, but if individuals may be on certain medications, the vaccine efficacy may not be as significant. So with those vaccines and live vaccines, certain live vaccines, because of its replication potential, and those who are the most immunosuppressed, so usually transplant, I guess, in individuals with disease who have kidney transplant.
Right. So there's a few more, thanks. There's a few more questions in the chat. So are there any initiatives to keep vaccination records up to date on Care Connect from GP offices or in hospital?
Yeah. So I don't know. What I do know is that currently the vaccine system in Canada is not working. The ability for us to track who's received what in Canada is very limited. It's reliant on individuals' personal records. One of the things that is being worked on is thinking about, should the vaccine change from its current and change to a model where Canada procures vaccines as a country and not come up from public health budgets. Because if we look at public health budgets across each of the provinces, vaccines, it's small, but then vaccines end up taking up a large part of that public health budget. And that's why it's so difficult for public health to then say, okay, we're going to fund this according to NACI. If they take that away from the public health budget and looking at a national budget, similar to like Canadian Blood Services approach, and do national procurement with a revitalization and modernization of supply chain, then you don't end up with wasted vaccine in one particular area because of oversupply and no access to some of these public health funded vaccines in certain other areas, because they have to drive to a public health unit to stock their offices, clinic offices, with limited supply. And so it's not a very effective system right now. The access to Care Connect is limited to certain providers. So for example, some of the trainees coming on don't get access to Care Connect or not provisioned for it. So even if they're looking for a vaccine record, they don't see it.
Yeah, so Panorama does, like, apparently the GPs, when they got paid for vaccination, had to enter it, but now that they're on a different funding mechanism, A, they're not doing it, but B, they also don't have to enter it. Whereas the pharmacies, if you go to the pharmacy, they have to enter it. So that does at least end up in Panorama. Now, access of that information to the healthcare person looking after them might be limited, but at least there is that record, is my understanding.
And then do you know if Panorama is linked directly to Care Connect immunization record tab?
Oh, it is. Okay, good.
No, that I don't know.
Oh, I don't know. It is directly linked to Promise. So the renal database for the province is directly linked. We get a dump every day from Panorama, so we know who's been vaccinated. Well, whoever's been entered in Panorama, we can see that. So that's nice. There's a couple of other questions before the time is out. Which vaccine should be given prior to immunosuppression? Rituximab or cyclophosphamide, prednisone?
Oh, okay. So in general, prior to immunosuppression, the general concept is to give the vaccine prior to immunosuppression and have at least 2 weeks. If it's going to be given after immunosuppression because someone initiated it, we know that the response is going to be significantly impaired. So with timing of, for example, prednisone, it's going to be ideally when the lowest dose of prednisone is achieved outside of the acute phase. So if they're on right. Prednisone, then it can be given. But with the CD20 depleting agent, that becomes really problematic afterwards. And so ideally, these vaccines, at least in initial series, has been started. So for example, the Shingrix vaccine, they can get their first dose prior to it, generally wait for at least 2 weeks, and then provide the.
Yeah, thank you. That's helpful for people. Yeah, I think that the pharmacies work quite well with the teams to make sure that we're managing the vaccinations with the rituximab at the same time. And the last question, which perhaps is for both of us, are we at a point in time where the evidence of cardiorenal benefits of the various vaccines can be translated into costs of health outcomes avoided for advocacy? So we are working with BC CDC and others to demonstrate within the renal population whether or not we're seeing a difference in cardiac events or hospitalizations and or trajectory of kidney disease over time in those vaccinated versus not vaccinated as a kind of natural experiment. But stay tuned. But I think that's what Victor was saying. Like, if we could explain that it's not just about reducing the infection and the hospitalization, but in the general population, additionally reducing cardiovascular events in the future, I think that's another reason, to your point, why it shouldn't be in a public health budget, just be in a health budget, right? So that you're not having to make decisions about what not to give. Mm-hmm. And you think that there's an appetite in the moment of the ministry to listen to this, or?
I think even if there's an appetite, the Treasury Board doesn't have the funding for it. So we've had discussions with the vaccine group at BCDC saying, even if we show the data, is that going to be helpful? And they're not hopeful. They're that hopeful that even with the economic data that it would be. Now that might change because with HPV, for example, one of the vaccines I didn't mention, that has been a change recently in the summer. So HPV vaccine, the one that's covered now, covers the two most common HPV serotypes that lead to cancer. So cervical cancer, rectal cancer, throat, head and neck cancer. Because of its significant impact on reducing cancer risk and the data globally, in British Columbia, the age groups have expanded on who they will cover. So if people miss the school age vaccination programs for HPV, they may still qualify. So one one restriction that's not based on age is for individuals with abnormal colposcopy, because the vaccine can show and delay recurrence of abnormal colposcopy findings. And so that is one indication, and that's covered. Individuals can get that in the pharmacies. They've also expanded the age group up to 45 years old, depending on risk. And so.
Great. No, thank you very much. Sadly, we're out of time. It's bottom of the hour, but thank you so much. And I'm sure, Carolyn, if you wanted to email Victor, he's very responsive to questions. So thanks, everybody. And thanks, Victor, for preparing and for the great education for all of us.
Thank you.
And that means that for today, when we all see all the patients in our outpatient clinics, we make sure that they've been vaccinated or at least ask the question. Thanks again.